we're going to talk about anemia drugs. Erythropoiesis, hematopoiesis is the formation of new blood cells. So this would be like white blood cells and red blood cells and platelets. Okay, takes place in the bones. The epiphysis of certain long bones and flat bones. This would be like in your skull, in your pelvis, in your sternum, your scapulae, and your ribs. Erythropoiesis is the formation of new red blood cells in the bone marrow. So the kidneys produce erythropoietin, which stimulate red blood cell production. The kidneys release erythropoietin into circulation. Okay. The bones produce reticulocytes, which are immature red blood cells. These immature red blood cells take about 24 to 36 hours to mature. Your red blood cells have a lifespan of about 120 days, which is important when you talk about different kinds of hemolytic anemias, which we'll discuss in level 3. The recipe for making red blood cells. You have erythropoietin, and remember this is from the kidneys. You have iron, folic acid, and vitamin B12, and these you're going to get from your diet. Okay. So anemia is basically just a decrease in red blood cells. There's a lot of different reasons why you have a decrease in red blood cells, but anemia is a decrease in red blood cells. So your maturation, it can be a maturation defect, which means it's a problem with creating enough red blood cells, which could either be a lack of materials. So remember, those materials would be like iron, your B12. Could be a kidney problem that's not making enough erythropoietin. Or it could be that the bone marrow is just not producing enough. So the bone marrow is not keeping up with what it should be doing. It could also be excessive red blood cell destruction, which is what we call hemolytic anemia. It can be intrinsic factors, which means it's inside the body. And that could be like a red blood cell is malformed or malfunctioned. So it's destroyed by the body quicker because the body is constantly checking the cells to make sure that they're what they should be, and if they're not, they're taken out by the spleen. The red blood cells are taken out by the spleen. So irregularly shaped red blood cells are going to be taken out of the body or taken out of circulation via the spleen. So they're going to be taken out quicker, and that would be a decrease in red blood cells because the body is getting rid of them at a quicker state. So they're not staying around for 120 days, right? An example of this would be sickle cell, which we will talk about in level 3. Extrinsic factors, that's a problem with the environment. So your body's making them fine, but for some reason there's something that's killing them off that's in your body. It can be an autoimmune disease, which is more likely the case where your immune system just suddenly starts attacking your red blood cells. A virus gets into your red blood cells, the immune system starts killing off the red blood cells. So that would be an extrinsic factor. So erythropoiesis stimulating drugs. So if you have a problem with erythropoiesis, so this is used when the bone marrow isn't producing enough. It could be a renal problem. It could be a bone marrow suppression issue. Okay. So the mechanism of action is to stimulate progenitor cells in the bone marrow. So it's to make reticulocytes. Okay. So it's going to stimulate the bone marrow to make little reticulocytes, which are baby red blood cells. Okay. So it's also going to speed up red blood cell maturation. So instead of taking 24 to 36 hours to mature, it's going to take less time. Okay. However, in order to have erythropoiesis stimulating drugs work, you have to have the recipe for making red blood cells. So you need to have adequate iron, and you actually have to have bone marrow function in order to be able to stimulate the bone marrow to be working. So there are different forms. You can give it sub-Q or you can give it IV. The adverse effects, you can get hypertension, and this will cause a headache, generally is what they say. And this is due to an increased number of red blood cells. All of a sudden you have a lot more red blood cells in your circulation. Those are taking up space. They're increasing your intravascular fluid volume, okay? Okay, so that is going to increase your blood pressure, okay? It can cause a thrombolytic event because you have so many more cells. So it could cause an MI, a stroke, could cause a DVT even, because you just have way more cells in your circulation than you usually do. And it can also cause seizures, and this happens if you have an increase in your hemoglobin and hematocrit that occurs really quickly. Okay, so if it occurs too quickly, it can cause seizures. Okay, so contraindications are things that are going to increase your risk for thrombosis. So this would be like an uncontrolled hypertension. So you already have hypertension, you don't want to give something that can potentially make that worse. If you have a hemoglobin greater than 11 with renal patients, or a hemoglobin greater than 10 with cancer patients, you don't want to give it, okay? Because if you give it, this will increase with cancer patients here. If you give it, it can increase the risk, increase our risk for developing tumors. So we're definitely going to be checking their hemoglobin and hematocrit prior to giving red blood, the erythropoiesis stimulating drugs. So we want to make sure we're going to monitor closely patients that are on chemo and on epoetin. Okay, so that's definitely something we want to catch. And notice that the hemoglobin is less than normal, okay? It's like low normal. We don't want it to be, we don't have to get it up to normal, okay? We just want it really close because we don't want to overload their system with a bunch of red blood cells, okay? So the FDA requires registration with the ESA, Apprise Oncology, which is a program that it educates physicians who may be ordering epoetin and let them know that the risk that if they give erythropoiesis stimulating drugs and they already have a tumor, that this could increase the risk of, it may make the tumor grow faster. So physicians have to go through a special education program, or prescribers have to go through a special education program that educates them on this, and then also they have to educate the patients on these risks, and the patient has to actually sign a waiver saying that they understand that they have a tumor and that taking the epoetin could increase the growth of this tumor and could make everything worse. So they have to have special consideration and education with this. Okay, so nursing considerations. Well, we don't want to administer with any other product, okay? You don't want to shake the vial because it can actually inactivate it. It will inactivate the medication. And if you inactivate it, it looks all foamy. What you really want to do is to just gently roll it between your hands, just like you would like insulin, okay? During the treatment, you want to monitor blood pressure and heart rate because we're monitoring for fluid overload, right? Labs, we're going to do hemoglobin, hematocrit, red blood cells, reticulocyte count, because we want to see, okay, how much, a reticulocyte count tells us how much immature baby cells, red blood cells, the bone marrow is currently churning out, okay? So we can see, okay, what is its current activity? And then if we give epoetin, which should stimulate the activity, we should see an increase in reticulocyte count if it is working properly. And then we want to give iron and B12, or we want to check iron and B12 levels, because we need those ingredients to be able to produce red blood cells to begin with. If we don't have enough building blocks, we can't build it, right? And then we will give supplements as needed. If they are deficient in iron or deficient in B12, then we will give those. So you want to monitor for effectiveness. How do we know that it's being effective? Well, yes, we'll look at the labs, but we also want to ask them, how they feeling? Do they have increase in energy, increase in appetite, stuff like that? They should feel better when their H&H is up to normal. So we want to, with patient teaching, we want to let them know that the therapeutic response may take 2 to 6 weeks, may take a little bit of time, and also the FDA risk evaluation and mitigation strategies. So their education on the potential risks, especially if they're on chemo, if they have a tumor, etc., things like that. We have to educate the patient about the risk with having a tumor and taking epoetin. Okay, so iron. Iron is a building block of red blood cells, so it could just be that they're iron deficient, and we call the iron deficiency anemia. So iron is best absorbed in the stomach on an empty stomach, okay? However, it is better tolerated with meals. We really educate them to take the iron without meals if they can, but if they can only tolerate it with meals, they just have to understand that less is going to be absorbed into their GI. Okay? So if taking it with meals makes them more compliant, then they need to just take it with meals. However, we prefer them to take it on an empty stomach if they can, because it's just better absorbed that way. Okay, so iron, it's stored in the liver, the spleen, and the bone marrow. Children and women require more iron. Sources are listed there. The forms we're going to be talking about in a little bit more detail, but they're listed there. Indications, if they have iron deficiency anemia, okay, so they're just not taking enough iron, we need to supplement that so their body can make those red blood cells, or we're giving them epoetin and they need more iron than they have currently because we're going to be stimulating them to make more red blood cells. They need the building blocks to do that. Adverse effects, GI distress, so this would be like nausea, vomiting. Constipation's huge, can also cause heartburn, okay? It can cause staining, especially if it's PO. It can stain their teeth. So they need to rinse after they take it PO or drink through a straw. With IM, it can actually stain their skin. So if you use a Z-Track method to give the IM, then it helps to decrease staining. Anaphylaxis. Dextran can cause anaphylaxis. So, it is required to do a test dose of dextran prior to giving a full dose. So that test dose, so you're going to give a test dose of 25 milligrams, and then you wait an hour, okay, because you're waiting to see if there's going to be any kind of reaction. As long as there is no reaction, then we can give the full dose, okay? But you always want to do a test dose with dextran prior to giving the full dose, okay? And always monitor for a reaction. So we're going to monitor for reaction. Now, just because there isn't a reaction in the first hour doesn't mean there's not going to be one. But more than likely, if there is a reaction, it's going to happen in that first hour. And we're going to monitor for any hypotension with IV or IM use. Okay, now we're going to talk about iron toxicity. Okay. Oh, okay, well, let's go back. Oh, hold on. Let's just stop it right there. Iron toxicity. Okay, so what does iron toxicity look like? Okay, so you have an increase in iron. This goes to the stomach. Okay. And this is where it wreaks havoc. Okay, so it can sit in the stomach. And it just sitting there in the stomach can cause ulcerations or holes. In the GI mucosa. Okay. These holes in the GI can cause bleeding and fluid loss. Which leads to hypovolemia. Which then leads to shock, hypovolemic shock. And all shock is, remember, all shock is decreased perfusion. So if hypovolemic shock means you have decreased perfusion to your organs, okay? Now, the other thing up here, you have dissolved iron. So that's iron that just sits in the belly. Now we have dissolved iron that goes out to circulation. What it causes, so you have liver, goes to the liver where it's stored. Okay? This can cause hepatotoxicity, which leads to decreased lactic acid metabolism. That's one of the functions of the liver, which then leads to increased lactic acid in the blood. And you get metabolic acidosis. Now the other thing that happens is that iron is it's a positive ion, so it's a proton, okay? So it eats up all the buffers that our body has. So we end up with an increased amount of acid, which is our protons, and also causes metabolic acidosis. So this is just a diagram to show you how iron toxicity can cause metabolic acidosis and it can cause hypovolemic shock. Okay, I don't know why that looks like that. Let me take that off. It's malfunctioning today. Okay, so contraindications for iron. If they have a previous hypersensitivity, of course. If they have anemias that are other than iron deficiency as the cause. So if their problem isn't that they don't have enough iron, then we're not going to give iron. That's not going to help the situation. That's going to, in fact, lead to iron toxicity. So we don't want that. Interactions. These are antacids, tetracyclines, caffeine, dairy products, food, these can actually decrease absorption of iron. Okay, and vitamin C will increase absorption, but it also causes an increase in GI upset because it's so acidic. Okay, your nursing considerations, monitor for GI symptoms. So this could be constipation, nausea, heartburn, stuff like that. And then toxicity, we talked about this already. So toxicity is an overdose. You have severe GI symptoms, can lead to shock and acidosis. This is actually the most common cause of pediatric poisoning because it used to be that their vitamins had iron in them and they made the vitamins taste good. And so kids would get into the bottle of vitamins and they would overdose on iron. Nowadays, really, iron's not present and a great deal in the vitamins anymore because of that. But it used to be. Now, for toxicity, you can use deferoxamine, and this binds iron so that it can't be free to wreak havoc, okay? Mostly cause the metabolic acidosis that we talked about. They need to remain recumbent for about 30 minutes after getting the IV dose so that it doesn't cause heartburn and issues like that. Remember, with dextran IV, we're going to do a test dose. We need to administer it slowly, so we need to make sure it's nice and diluted and, at the proper rate. Okay, we need to have emergency equipment at the bedside because of the potential for anaphylaxis. Okay, so they remain recumbent for 30 minutes after administration because to prevent orthostatic hypertension. Okay, we can pre-medicate them to help prevent a reaction. We can give them diphenhydramine, which is Benadryl, and acetaminophen or hydrocortisone to help prevent that. Okay, so patient teaching, they need to increase their water and fiber intake. And exercise, this is going to help prevent constipation. We want to encourage intake of foods that are high in in iron, because it's better if they get it through their foods and not supplemented. They need to take on empty stomach if they can. If the GI upset is intolerable, then they can take it with meals. It will, though, decrease absorption. So they just need to know that. If they're taking adequate amounts, their stools should be dark green and black or to black colored. Okay, stools. So this would indicate that they're taking a good therapeutic amount. Okay. So if their stools are not dark green or black, then that means they're not getting enough. Okay. This is something we often would tell parents of infants that were anemic, which is a common thing with breastfeeding infants. And so we would tell them, well, that they're getting enough iron if their stools are dark green or black. So we want to tell them about preventing staining with diluting the liquid, drinking through a straw, rinsing their mouth out, and then remaining sitting for 30 minutes after administration to help decrease the GI symptoms. the IV ones is to decrease, or the static hypotension. So, but with PO, it's to help with the GI distress, help decrease the GI distress. Okay, so folic acid. Folic acid is needed for production of DNA and erythropoiesis. Okay, it's absorbed in the duodenum. Many malabsorption syndromes can cause this. So if you have a malabsorption issue in the duodenum, it's going to cause a vitamin B9 deficiency. So your dietary sources are there. It's either PO or injection. Adverse effects, it can mask a B12 deficiency. B12 is needed to convert folic acid into its active form. So if you don't have B12, then you can have a deficiency in folic acid. But you want to make sure that if you have a decrease in folic acid, it's not because you have a B12 deficiency. So you need to make sure that the B12 level is good. Interactions, decrease absorption with methotrexate and sulfonamides, increase absorption with phenytoin. Nursing considerations, we want to monitor for risk factors indicating the need, which would be like alcoholism and pregnancy. It is used for the prevention of neural tube defects, which you'll probably learn about when y'all talk about pregnancy. Also teaching, let them know that they should take it 1 month prior to getting pregnant, because it really needs to be in their system before they start forming a fetus, to make sure that it forms as well as it can. Okay, so assessment, we want to assess and document signs and symptoms of anemia. Do they have any allergies? Do they have any contraindications? Do they have any drug interactions? Adequate stores. Do they have enough iron, B12, folic acid, B12 and folic acid, which is B9, okay? We need baseline vital signs because it may increase the blood pressure. And we also need to know their H&H levels. So we're going to need to know those, okay? Hemoglobin, hematocrit. Ask questions regarding energy levels, ability to carry out activities of daily living, overall immunity to illness, do they get sick easily or not, and just their state of health, because these are really going to help us determine effectiveness of the medication. Is it getting better? Are you getting better? It's really going to help us figure out if it is. Evaluation, we want the hematocrit to be between 10 and 11. Remember, we don't want it up at normal. The maximum hemoglobin is 33%. So that should be a B right there. Okay. We want to evaluate for increased appetite, energy, and sense of well-being, because this will say it's a good therapeutic response, okay? So that's what we're looking for.